The management of third and fourth degree perineal tears. Green Top Guideline number 29, June 2015. Introduction and background epidemiology. The overall incidence in the UK is 2.9%, range from 0 to 8%, with an incidence of 6.1% in primipary compared with 1.7% in multipary. A trend towards an increasing incidence of third or fourth degree perineal tears does not necessarily indicate poor quality care. It may indicate, at least in the short term, an improved quality of care through better detection and reporting. Classification and terminology. How should obstetric anal sphincter injury be classified? It is recommended that the classification outlined in this guideline be used when describing any obstetric anal sphincter injury. If there is any doubt about the degree of third-degree tear, it is advisable to classify it to the higher degree rather than the lower degree. The following classification described by Sultan has been adopted by the International Consultation on Incontinence and the Royal College of Obstetricians and Gynecologists. First-degree tear, injury to perineal skin and/or vaginal mucosa. Second-degree tear, injury to perineum involving perineal muscles but not involving the anal sphincter. Third-degree tear, injury to perineum involving the anal sphincter complex. Grade 3A tear, less than 50% of external anal sphincter or EAS thickness torn. Grade 3B tear, more than 50% of external anal sphincter thickness torn. Grade 3C tear, both external anal sphincter and internal anal sphincter or IAS torn. Fourth-degree tear, injury to perineum involving the anal sphincter complex, both external and internal anal sphincters, and anorectal mucosa. Obstetric anal sphincter injuries, or OASIS, encompass both third and fourth degree perineal tears. Anal incontinence is defined as a complaint of involuntary loss of flatus and/or feces affecting quality of life. The internal anal sphincter plays a role in the maintenance of continence. Inclusion of the internal anal sphincter in the classification above would allow differentiation between future incontinence related to internal anal sphincter injury and that related to external anal sphincter injury alone. Identification of the internal anal sphincter may be difficult in acute obstetric trauma, but every attempt should nonetheless be made to exclude and document injury to the internal anal sphincter. Recording the degree of external anal sphincter damage, more or less than 50%, should be possible in all cases. If one is unsure whether it is more than 50%, then it should be classified as 3B to avoid underestimation. Rectal buttonhole tear. If the tear involves the rectal mucosa with an intact anal sphincter complex, it is by definition not a fourth-degree tear. This has to be documented as a rectal buttonhole tear. If not recognized and repaired, this type of tear may lead to a rectovaginal fistula. Prediction and prevention of obstetric anal sphincter injury. Can obstetric anal sphincter injury be predicted? Clinicians need to be aware of the risk factor for obstetric anal sphincter injuries. Clinicians should be aware, however, that risk factors do not allow the accurate prediction of obstetric anal sphincter injuries. The following risk factors have been identified. Asian ethnicity, nulliparity, birth weight greater than 4 kilograms, shoulder dystocia, occipito-posterior position, prolonged second stage of labor, and instrumental delivery. Risk factors for sustaining recurrent obstetric anal sphincter injuries in the subsequent pregnancy include Asian ethnicity, forceps delivery, and birth weight more than 4 kilograms. Can obstetric anal sphincter injury be prevented? Clinicians should explain to women that the evidence for the protective effect of episiotomy is conflicting. Mediolateral episiotomy should be considered in instrumental deliveries. Where episiotomy is indicated, the mediolateral technique is recommended, with careful attention to ensure that the angle is 60 degrees away from the midline when the perineum is distended. Perineal protection at crowning can be protective. Warm compression during the second stage of labor reduces the risk of obstetric anal sphincter injuries. Episiotomy. A 60-degree episiotomy from the center of the introitus results in a post-delivery angle of 45 degrees. Perineal protection. The positive effects of perineal support suggest that this should be promoted as opposed to hands-off or poised in order to protect the perineum and reduce the incidence of obstetric anal sphincter injuries. Warm compress. The intervention involves holding the compress on the perineum continuously during and between contractions. Perineal massage during antenatal period and in second stage of labor. Perineal massage undertaken by the woman or her partner was associated with an overall reduction in the incidence of trauma requiring suturing. Women practicing perineal massage were less likely to have an episiotomy. These findings were significant for women without a previous vaginal birth only. Identification of obstetric anal sphincter injuries. How can the identification of obstetric anal sphincter injuries be improved? All women having a vaginal delivery are at risk of sustaining obstetric anal sphincter injuries or isolated rectal buttonhole tears. They should therefore be examined systematically, including a digital rectal examination to assess the severity of damage, particularly prior to suturing. Systematic assessment of genital trauma should include further explanation of what the healthcare professional plans to do and why, confirmation by the women that effective local or regional analgesia is in place, visual assessment of the extent of perineal trauma to include the structures involved, the apex of the injury, and assessment of bleeding. A rectal examination to assess whether there has been any damage to the external or internal anal sphincter if there is any suspicion that the perineal muscles are damaged. The woman should usually be in the lithotomy position to allow adequate visual assessment of the degree of trauma and for the repair itself. The systematic assessment and its results should be fully documented, preferably pictorially. The woman should be referred to a more experienced healthcare professional if uncertainty exists as to the nature or extent of the trauma sustained. Since the introduction of endoanal ultrasound, sonographic abnormalities of the anal sphincter or occult injuries have been identified in 33% of women following vaginal delivery. However, when endoanal ultrasound was performed immediately following delivery, the detection rate of obstetric anal sphincter injuries was not significantly increased compared with clinical examination alone. Repair of obstetric anal sphincter injuries. General principles. Repair of third and fourth degree tears should be conducted by an appropriately trained clinician or by a trainee under supervision. Repair should take place in an operating theater under regional or general anesthesia with good lighting and with appropriate instruments. If there is excessive bleeding, a vaginal pack should be inserted and the woman should be taken to the theater as soon as possible. Repair of obstetric anal sphincter injuries in the delivery room may be performed in certain circumstances after discussion with a senior obstetrician. Figure of 8 sutures should be avoided during the repair of obstetric anal sphincter injuries because they are hemostatic in nature and may cause tissue ischemia. A rectal examination should be performed after the repair to ensure that sutures have not been inadvertently inserted through the anorectal mucosa. If a suture is identified, it should be removed. Regional or general anesthesia will facilitate identification of the full extent of the injury and enable retrieval of the retracted ends of the torn anal sphincter. Which techniques should be used to accomplish the repair of the anorectal mucosa? The torn anorectal mucosa should be repaired with sutures using either the continuous or interrupted technique. Which techniques should be used to accomplish the repair of the internal anal sphincter? Where the torn internal anal sphincter can be identified, it is advisable to repair this separately with interrupted or mattress sutures without any attempt to overlap the internal anal sphincter. A separate repair of the internal anal sphincter improves the likelihood of subsequent anal continence. Which techniques should be used to repair the external anal sphincter? For repair of a full thickness external anal sphincter tear, either an overlapping or an end-to-end approximation method can be used with equivalent outcomes. For partial thickness, all 3A and some 3B tears, an end-to-end technique should be used. The overlap technique can only be used for full-thickness external sphincter tears to allow the torn ends to be overlapped without tension, and this technique has only been described to repair full-thickness external anal sphincter tears. As two free ends of the muscle are needed for a proper overlap repair, overlapping of partial thickness external anal sphincter tears would exert undue tension on the repair. Therefore, an end-to-end repair should be performed in a partial thickness external anal sphincter tear, 3A and some 3B. Choice of suture materials. Which suture materials should be used to accomplish repair of obstetric anal sphincter injuries? Polyglactin should be used to repair the anorectal mucosa as it may cause less irritation and discomfort than polydioxanone or PDS sutures. When repair of the external anal sphincter and/or internal anal sphincter muscle is being performed, either monofilament sutures such as 3-PDS or modern braided sutures such as 2-polyglactin can be used with equivalent outcomes. When obstetric anal sphincter repairs are being performed, the burying of surgical nuts beneath the superficial perineal muscles is recommended to minimize the risk of knot and suture migration to the skin. The use of PDS or polydioxanone sutures for repair of the anorectal mucosa should be avoided as they take longer to dissolve and may cause discomfort in the anal canal. Suture migration and its management. Suture migration is recognized when a woman complains of irritation or pain around the perineum after repair of obstetric anal sphincter injuries. This may also be detected at the time of examination where the exposed ends of suture material are seen or felt on digital examination. Exposed suture ends can be trimmed in the outpatient setting under local anesthesia. The reported incidence of suture migration is about 7%, and this can be reduced by trimming the suture ends and burying the knots in the deep and superficial perineal muscles. Surgical competence. Who should repair obstetric anal sphincter injury? Obstetric anal sphincter repair should be performed by appropriately trained practitioners. Formal training in anal sphincter repair techniques should be an essential component of obstetric training. Inexperienced attempts at anal sphincter repair may contribute to maternal morbidity, especially subsequent anal incontinence. Published randomized controlled trials have reported residual external anal sphincter defects in 19 to 36% overall following repair. Post-operative management. How should women with obstetric anal sphincter injury be managed post-operatively? The use of broad-spectrum antibiotics is recommended following repair of obstetric anal sphincter injuries to reduce the risk of post-operative infections and wound dehiscence. The use of post-operative laxatives is recommended to reduce the risk of wound dehiscence. Bulking agents should not be given routinely with laxatives. Local protocols should be implemented regarding the use of antibiotics, laxatives, examination and follow-up of women with obstetric anal sphincter repair. Women should be advised that physiotherapy following repair of obstetric anal sphincter injuries could be beneficial. Women who have undergone obstetric anal sphincter repair should be reviewed at a convenient time, usually 6 to 12 weeks postpartum. Where possible, review should be by clinicians with a special interest in obstetric anal sphincter injuries. If a woman is experiencing incontinence or pain at follow-up, referral to a specialist gynecologist or colorectal surgeon should be considered. Laxatives are recommended during the post-operative period as passage of a hard stool may disrupt the repair. Use of stool softeners such as Lactulose is recommended for about 10 days after the repair. The dose of Lactulose should be titrated to keep the stool soft but not loose. It is appropriate to review women in the postnatal period to discuss injuries sustained during childbirth, assess symptoms, and offer advice on how to seek help if symptoms develop, offer treatment and/or referral if indicated, and offer advice on future mode of delivery. Use of a validated health-related quality of life questionnaire may be useful for assessment of women who develop anal incontinence after sustaining obstetric anal sphincter injuries. If facilities are available and resources allow, follow-up of women with obstetric anal sphincter injuries should be in a dedicated perineal clinic with access to endoanal ultrasonography and anal manometry, as this can aid decision making regarding future delivery. Prognosis. What is the prognosis following surgical repair? Women should be advised that 60 to 80% of women are asymptomatic 12 months following delivery and external anal sphincter repair. Future deliveries. What advice should women be given following an obstetric anal sphincter injury concerning future pregnancies and mode of delivery? All women who sustain obstetric anal sphincter injuries in a previous pregnancy should be counseled about the mode of delivery, and this should be clearly documented in the notes. The role of prophylactic episiotomy in subsequent pregnancies is not known, and therefore an episiotomy should only be performed if clinically indicated. All women who have sustained obstetric anal sphincter injuries in a previous pregnancy and who are symptomatic or have abnormal endoanal ultrasonography and/or manometry should be counseled regarding the option of elective cesarean birth. The risk of sustaining a further third or fourth degree tear after a subsequent delivery is 5 to 7%. The risk of a subsequent vaginal delivery after a third degree tear have been assessed, with 17% of women developing worsening fecal symptoms after a second vaginal delivery. This seemed to occur if there had been fecal incontinence beyond 3 months, but resolution by 6 months after the index delivery. Risk management. What processes and policies should be in place for women who have sustained obstetric anal sphincter injuries? Units should have a clear protocol for the management of obstetric anal sphincter injuries. Documentation of the anatomical structures involved, the method of repair, and the suture materials should be made. The woman should be fully informed about the nature of her tear, and the offer of follow-up should be made, all supported by relevant written information. There has been a rise in litigation related to obstetric anal sphincter injuries. The majority of cases are related to failure to identify the injury after delivery, leading to subsequent anal incontinence and rectovaginal and anovaginal fistulae. At present, the occurrence of obstetric anal sphincter injuries is not considered substandard care because it is a known complication of vaginal delivery. However, failure to recognize anal sphincter damage or carry out an adequate repair may be considered substandard care. A poor technique, poor selection of materials, or poor healing may cause a repair to fail. Clear documentation, preferably using a drawing, together with providing the women with an explanation and patient information leaflet is important.